The title of this session is Getting to the Heart of Digital Health, Improving Cardiac Care Without Skipping a Beat. And I'm delighted that STAT's Erin Brodwin is going to be joining us to moderate today's session. This is such an important conversation. There's been tremendous scholarship around sort of the promise of digital innovation to really improve cardiac care. And we have a phenomenal panel here. Erin, just before I hand you the reins to sort of guide us through this conversation, just a quick note, we've had lots of tremendous questions from folks about availability of slides and recordings. For everyone who is on the line now, we will be sending out slides and recordings directly to you tomorrow, along with additional opportunities to engage. Later this week, all of these resources will also be available on the DIME website. So definitely stay tuned in, and if this is something that would be interesting to your colleagues, those resources will be available later this week, along with other opportunities for you to continue to engage with this ongoing conversation. And with that, Erin, let me hand the reins over to you. Thank you so much for being here today. I always learn so much from your work. Your journalism on health tech has been sort of fostered some of the greatest learnings for me, and I'm really excited to see how you guide our experts through the conversation today.
Awesome. Well, thank you so much, Jen. That is quite a compliment. I really appreciate that. I'm seeing in the chat that some attendees are saying they can't see video. So please continue to send messages in the chat if you cannot see video. If you can, all good. I'm going to continue to talk, but I'll take the intro a little bit slow just to make sure everybody can tune in and see everything. So again, I'm Erin. I'm a health tech reporter with Stat News, and it is my pleasure to get to share the stage with such an awesome panel of experts here. First and foremost, I'm going to introduce Dr. Amit Shah, an assistant professor of epidemiology at Emory University. He has an adjunct appointment in cardiac medicine and staffs the outpatient clinic and inpatient consult service at the Atlanta VA Medical Center. So couldn't imagine a more perfect person to kick off the discussion. Just Dr. Shah, don't forget your slides.
Thank you so much. It's an honor to be here. I am loading them now and put them in presentation mode. All right. So it's an honor to be here to talk about cardiac rehab in the digital era with our VA Smart Heart program, HEART standing for Health Education and Rehab Technology. Heart disease is the #1 cause of veteran death, but largely preventable. Some estimates show that 80% of heart disease events are preventable. Prevention programs such as cardiac rehabilitation, however, are very difficult to implement. And it's estimated that less than 20% of eligible veterans receive cardiac rehabilitation care after their cardiac event. In many cases, this is multifactorial: cost, travel, disability. These are some of the reasons. This is a huge missed opportunity for prevention, resulting in wasted effort and costs. The COVID pandemic has made things worse from the perspective of cardiac care and cardiac rehabilitation. Normally, veterans would go into a hospital and they would receive monitored, supervised exercise. But with the pandemic, there's been an increased risk of COVID spread with exercise. And this has really focused the shift, unfortunately made it much harder to implement cardiac rehabilitation. The solution that we are seeking and forced to seek during the pandemic has been a virtual version of this exercise comprehensive lifestyle change program, in which the paradigm has shifted from center-based exercise at a hospital to home exercise. Home-based cardiac rehabilitation is our virtual version of traditional cardiac rehabilitation, in which a coach guides veterans over weekly telehealth visits to exercise at home, and also counsels them on nutrition and stress management, amongst other supportive aspects of care. Our digital solution in the Smart Heart program involves using mobile apps to collect patient-reported outcomes from veterans, wearables to do exercise tracking, connected devices such as Bluetooth-enabled blood pressure monitors, personalized coaching with telehealth visits, and care coordination with a coach involving analytics in the cloud. Veterans that enroll in our program receive the technology And then this includes a smartphone app, as well as a Fitbit, and their blood pressure monitor and scale. And then they have an onboarding visit to teach them how to use the technology and make sure that they can log in. They then conduct weekly telehealth visits, and their coach can manage their health over a dashboard. Together, then, they work towards improving their lifestyle and reducing their risk factors through comprehensive lifestyle change. Veterans that have enrolled in our program have done very well. So compared to veterans who were referred for cardiac rehabilitation but did not attend, in which the one-year event rate was close to 19%, veterans who enrolled in the Smart Heart program had about a 5% one-year event rate, which was similar to center-based cardiac rehabilitation, which is the standard of care, and slightly lower than home-based cardiac rehabilitation without the technology. When considering a tech-based approach for cardiac rehabilitation, there are some very important considerations, especially when thinking about the VA. First of all, the VA, we use social security numbers as identifiers for veterans in the medical record. And this increases the need to take special security measures. Also, in working with the Department of Defense, there are national security risks to data breaches. And the VA has established programs through Project Special Forces to help new technologies integrate with them. Contracting is another consideration as we think about working with the VA. This process can take more than 6 months, and it involves a multi-step bidding process and also multiple checkpoints along the way to ensure fairness and also social justice for veterans, for example, working preferentially with veteran-owned small businesses. As we've been working with the Smart Heart program over the past 4 years and our vendor Moving Analytics, there have been several questions that have come up as we've worked towards integrating this with mainstream cardiac preventive care. First of all, as we think about new technologies, one consideration is how do we shorten the onboarding process for these new technologies to really empower the VA and allow us to provide to veterans the best approaches to tech-enhanced cardiac care. And with new or existing vendor partnerships, how do we minimize the friction on both the patient and provider side? So for example, what's the method through which we sign on to the program, both from the patient side and the provider side? Is the program integrated with the electronic medical record system, or do we need to log into a separate program and then manually consider both? What are the policies that we can use to optimize our clinical experiences? As we think about programs such as ours, in which there is a dashboard for us to look at our entire patient panel, we do need protected time to analyze those data. As we think about new technologies and making changes from our existing clinical paradigms to these tech-enhanced paradigms, are we funding the time for staff to train and also giving them flexibility for troubleshooting? Are we also providing them the necessary support, knowing that it takes specialized training to offer technological support to both patients and providers? And lastly, as we think about workload credit and accountability, are these systems generating workload credit sufficiently to justify the time that it takes? So for example, we can think about the number of relative value units per hour of effort in offering digital care versus the more traditional paradigm of standard clinic visits. So that's all I have. Thank you very much.
Thanks so much, Dr. Shah. Looks like I was muted there for a second. Pardon the minor technical difficulties on my end. That was great. I just want to jump right into things since we are a little limited on time. And I wanted to welcome Priya Abani next. She is the Chief Executive Officer of Alivecor. Before she led Alivecor, she was actually the general manager of Alexa voice service at Amazon, where she helped lead the expansion of Alexa technology into partner products. So same reminder for you, Priya, please don't forget your slides. I'll let you take it away.
Thank you so much, Erin. Give me 1 minute. Can you see my slides, please? Erin,
Yeah.
can you see my slides?
Yeah.
Okay, perfect. Thank you again, Erin, and thank you, Dr. Shah, and thank you, VHA Innovation and Digital Medicine Society for inviting me to participate in this discussion. There's no more important time to talk about the role of digital tools in our healthcare system and specifically how we can benefit the population that has served our country and their families. Before joining Alivecor, as Erin mentioned, I spent 2 decades in the tech industry. My background positioned me well, I think, to figure out how to get our cardiac technology into the hands of millions of people around the globe, including those who do not have proper access to healthcare. Today, I'll be speaking about Alivecor's work in remote cardiac monitoring and how we are leading the transition to patient-centric heart care. So let me start off with why we exist. Every 1.69 seconds, somebody in the world dies from heart disease. The unfortunate truth is that outside of the hospital setting, cardiologic care is a single point of failure. And in engineering terms, the heart is simply off network and unmonitored. So we at Alivecor are determined to improve the statistic, especially the human cost. In the United States, heart disease is the #1 cause of death, more than all forms of cancer combined, unfortunately. And we know that heart disease hits veterans especially hard, with a significantly higher prevalence of hypertension, coronary heart disease, and heart attacks. In addition, diabetes and obesity are highly comorbid with cardiovascular disease. And together, all of these account for substantial healthcare costs. The direct and indirect cost of CVD, diabetes, and obesity is more than $800 billion annually in the US alone. And as I stated before, reducing the human cost and the human impact and the economic impact of these disease states is what drives us at Alivecor. So our mission, we try to keep it simple. Our mission is to save lives and transform cardiology as the trusted provider of remote and connected cardiac care services for the 99% of the time when patients are not in front of their physician. We do this by delivering digitally accessible, clinically integrated, secure, high-quality cardiac services to consumers, providers, and payers. This mission is especially critical today because we know that we're in the tipping point in the healthcare industry. The regrettable truth is that in most cases, patients are just not in control of their own healthcare. It is the systems and unfortunately the antiquated workflows that determine almost everything about care a patient can receive. So as we all know, healthcare now more than ever before rapidly is moving out of the traditional clinical environment and into people's homes. And I really believe that previously complex procedures and monitoring can now be done with simple, more affordable devices powered by connected and connected cloud services, enabling empowered patients. And today, more and more patients are discovering that they can be directly involved and actively participate in their own care plans. So now let's talk about how digital health is enabling this moment in heart care. Many of you know that the ECG or the electrocardiogram is the primary diagnostic tool for which physicians use to evaluate the electrical activity of the heart. What you don't know is, or you might not have researched this, is that the basic technologies by all accounts is more than 150 years old. So while there have been improvements in size and accuracy over the years, the technology really did not meaningfully change until about 10 years ago. When I do believe that our founder, Dr. David Albert, devised a way to create a tiny portable device the size of a chewing gum that you can actually pair with your smartphone and deliver an FDA-cleared medical-grade ECG anytime, anywhere. And we not only record these ECGs, but our algorithms are able to take instant determinations as to what the ECG is telling them about their heart, about their heart health. So this little animation tells you all the FDA cleared determinations that we currently have in our apps. As importantly, we're able to tell patients when their heart rhythm is normal, giving them enormous peace of mind with the confidence that they do not need to call their physician, visit an urgent care facility, or rush to an emergency room. And in the avoidance of these episodes, I really believe that we not only improve the patient experience, but we actually reduce the utilization of some of our healthcare's most precious resources. Today, we offer the world's only FDA-cleared 6-lead personal ECG monitor. We offer the most clinically validated personal ECGs in the world, as well as our devices have been subject to more than 160 peer-reviewed studies. We have delivered more than 100 million ECG recordings with our 1.3 million lifetime users. We offer the world's only consumer heart care subscription program, which gives our customers access to both certified cardiologists, advanced determinations, monthly heart health reports, and so much more. So it's not just the sensor data, but it is what do you do with the data. We are now available in 42 countries to serve patients, health systems, leading medical and research centers, and we are proud that we have begun to serve a number of the VA clinics. This is how we're leading the transition to patient-centric heart care. So we can monitor and manage the heart health of users via our medical group 24/7 with the readers, with the algorithms, and when needed, clinical expertise. Access to heart care services and cardiology specialists is a major problem to most of the world's population, even in developed countries with robust medical systems. So with the digital services backed by clinicians, we can make these scarce services available to users anytime and anywhere. And finally, I think we have built the world's largest AI-driven consumer subscription service for cardiovascular care, which leverages, basically deep machine learning and connects patients directly with these cardiologists and coaches for additional support. The driving force behind everything we do is to aim to solve some of the system's core issues. Like the VA, we are committed to integrating digital health into cardiac care to facilitate effective, efficient, and equitable care. This is obviously a lofty goal. And so let me share some of the ways we're making progress. So the first thing is the ability to provide 24/7 digital services by hence lowering the cost of care for people with heart arrhythmias. Second, we are expanding the access to care to those who need it the most. As I mentioned, the demand for cardiologists far outpaces the supply. And this was a driving factor in developing some of our current and future subscription services. We also acknowledge that access to care is a challenge for VA facilities, which is why the VA's work to integrate digital health solutions is so important. And then finally, our portfolio of devices and services enhances patient outcomes. Just this year, new published data showed that people using our devices were less likely to have outpatient office visits and emergency department visits related to their arrhythmias. Our devices and services span a range of capabilities and use cases, and the element we focus on is their ability to enable new levels of remote cardiac care unlike ever before. So our offerings, both that are available today and those in development, and some of them are shown here, are moving us from a state of healthcare with, I would say, opaque diagnostics to a new age of empowered healthcare that is patient-focused, transparent, and offers the patient a feeling of control and peace of mind. So finally, I think the last 2 years have shown us that our systems have much work to do, but we have also witnessed a strong desire among both patients and providers for healthcare empowerment and remote care. So I think every effort that we all make collectively in the system is, or every effort we make in progress today should have the aim of making us ready for the future. We say that we are the heart of remote medicine, and it is our ambition to be just that. So thank you so much for your time today, and I'm going to turn it back to Erin.
Thanks so much, Priya. First of all, I just want to say I love the audience energy that I'm seeing in the chat right now. You all are asking sharp questions. You're sharing experiences with some of the devices that are being mentioned. Keep it coming. So sharing the stage with me today is, as I said, an all-star lineup of experts. We've already heard from 2 of them, and hopefully we're going to hear from a lot more. But with this many people on one panel, I just want to dive right in here. So I'm going to ask each of you to briefly introduce yourself while also answering a question that will kick off the discussion. Does that sound okay, everyone? I'm seeing thumbs up. Great, great. Okay, so I've chatted with all of you recently about a stark reality, which is that we are witnessing the largest decline in overall health in history. The largest decline in overall health in history. So Priya brought in some insight about patients not being in control of their care. Amit brought in some knowledge about the lengthy process required to onboard patients in tech-enabled solutions. And I guess I'm just thinking, you know, against this kind of stark and, you know, terrible backdrop, what role do you all think technology should play in improving cardiac care and, importantly, in reducing inequity? Rob, can we start with you?
Sure, thanks. Erin, Rob Califf. I'm a senior advisor at Verily Life Sciences and Google Health, and it's good to be with you. I would qualify your statement, Erin, to begin with, just saying it's the largest decline in U.S. recorded history and life expectancy, because actually in the rest of the world, other than the pandemic, things are headed in the right direction in terms of outcomes. The U.S. is singular in terms of the experience that we were having before the pandemic with life expectancy, and now we're seeing a 5-year shorter life expectancy than other high-income countries. So it's quite dramatic and worrisome. I would just say, you know, in brief, in the alphabet universe, we're reaching almost every person almost every day in one way or another related to health. So if you ask the question, how do you get to the clinic? How do you get your questions answered about medical information? For example, downloads about COVID on YouTube, 500 billion since the start of the pandemic. So people are accessing our technologies every day for that purpose. And on the Verily side, we're very involved in, you know, what would be called disease management. And I think the previous panel did a pretty good job of making the point that we're have far more people with diseases, and specifically cardiovascular diseases, than people who can provide all the hands-on care right now. We'll get into later exactly how that goes. In the interest of time, I'll just stop there.
Got it. Let's see. I think, Doris, I would love to hear from you here. You have some direct experience. What kinds of tools have you used, and what are some of their biggest strengths and weaknesses? Is Doris here?
Good morning, everyone. Thanks for having me. I am actually a transplant recipient. So what haven't I used? I have gone to the internet, of course, and I was also involved with the, I guess, the beginning stages of the study that the VA had, I guess, about 5 years ago now, and and it was helpful, but it was kind of hard. It wasn't user friendly. As a recipient, it wasn't user friendly at all, so it was difficult. And thinking back, I can't remember how long it was. I think there would need to be a more friendly, user-friendly device. Actually, you know, I have gone to Google. I mean, in the beginning stages, I didn't know what heart transplant was. I've never heard of it before. So yeah, you do go to these places like Google and YouTube to find out, you know, what is the process. I've never seen it before. I actually personally couldn't watch it myself, you know, as a patient. So those are the things that I have used in the past. And also I've used smartwatches. You know, I have an Apple phone. I use that. I use my watch. But some of those things aren't really, to me, they're not used as personal as a recipient. You want to see things real time. You want to see your progress, actually. You know, you want to set goals, you know, for your recovery. And that was most important for me, to see my goal from day one of having my transplant to today. I actually set a goal when I had my transplant to run the annual Peachtree. I don't know if you guys know anything about Atlanta and this Peachtree road race that is a 6.2 mile race. And I set that goal right after I had my surgery. So I had to, you know, set that goal, and each day basically document what my goal was for, you know, the future. So something that would, you know, basically help me journal my journey, I guess, you know, from day to day. Something that's very, you know, hands-on. So yeah.
That's really helpful, Doris. Thank you for that. Okay, I want to hear from everybody else, intros and quick, you know, starter questions. Just as a reminder, the question was, what role do you think technology should play in improving cardiac care and reducing inequity, again, against the backdrop of this sharp decline in overall health that we're seeing in the US? Who wants to take it away next?
This is Maulik. I'm happy to go. Can you hear me?
I can.
Okay. Hi, folks. My name is Maulik Majmudar. I'm a cardiologist. I'm the chief medical officer at Biofourmis, but prior to this, spent a few years at Amazon, and as well as 10 years at Mass General Brigham. So to answer your question, you know, Erin, the way I look at this in terms of role of technology, I think is twofold, right? There are diseases in cardiology and outside of cardiology where you truly need discovery and invention, innovation to advance the science and medicine, practice of medicine. And that's technology can help in traditional sense of drug discovery, efficiency, and things like that. But I think what I'm more focused on, Biofourmis is more focused on, is probably the bigger problem, which is implementation gap. I feel like one of the major challenges right now has been, there's been a lot of great discoveries and advancement in science, but unfortunately, for whatever reason, it doesn't get to the patients. You look at something as simple as use of statins after a heart attack, it's like less than 50%. Or you look at heart failure, completely morbid disease, 50% mortality at 5 years, and less than 1% of patients nationally are on the right drugs at the right doses. So this evidence practice gap is where I think technology can play a tremendous role in terms of standardization of care, quality of care, and driving, to Doris's point, more patient self-empowerment and control into their own outcomes. So without going too much in detail about Biofourmis, you know, we're really focused on two things. How do we leverage software to drive therapies, develop new digital therapies? Then how do you use software to actually deliver care in a virtual, remote way across the care continuum of acute, post-acute, and chronic care? Let me pause there. I'll answer questions later.
Awesome. I appreciate that. Patrick, do you want to take it away next?
Yeah, happy to. Hi, Patrick Wayte. I run the American Heart Association's Center for Health Tech and Innovation. And, you know, I think to Maulik's point and others, Dr. Shah's as well, that for us, one of the key things that we're trying to do is align the science in its various forms up and through and in relation to a wide range of digital health solutions. That really is still the core product of the American Heart Association. As Maulik noted, one of the things that we believe is very exciting about digital health is its ability to reach people at scale. Dr. Califf noted this as well. And to Maulik's point too, the reality is there is this gap of putting the science into practice in the right way at the right time, educating folks on their own so they can self-administer care to a certain extent, take care of themselves, but also collectively work with their loved ones and social support and really map back into clinical care. And these are really the key components and opportunities to improve care over time. And we're highly focused with our relationships, and full disclosure, we're working with both Alivecor and Biofourmis in different ways. But fundamentally, we're very focused with these relationships on producing evidence-based results, and not just putting information and systems out there, but really trying to publish and understand what's working and what's not. So it's an exciting time in digital health and health tech and telehealth and all their various forms. And we're thrilled to be here and also working with a range of great companies.
Awesome. Thank you. Susan, do you want to go next?
Sure, happy to. Hello, everyone. Susan Mani. I'm the AVP for Population Health Strategy at Humana. Just want to echo a lot of what folks are saying here. I think we clearly see the ability of digital health in terms of access. I would also say that once we start using digital tools, it also gives us the sense and understanding of what access really looks like and where the challenges are. When you start also thinking about things like digital literacy and what that might require us to actually put in place, also even digital penetration, internet penetration of different places, what does that need to look like? And I know several panelists before in one of the other sessions had mentioned that. Also think engagement. When we have a digital tool, we have to think about engagement deeply. What does engagement mean? It looks very different to different populations and members. So we really have to think about that. And couldn't agree with Doris more. This is really moving from education to the continuum of empowerment. If we think about primary and secondary prevention and cardiovascular disease, I think one of the tenets all of us from a physician standpoint think about is behavior change. So how can we really think about digital tools to really assist in the empowerment and behavioral change that's required?
Great. Thanks so much for that. All of these points are really great to just continue the discussion. And I guess since we are digitally speaking in a way sort of at the VA today, I want to talk a little bit more about that. Does each of you see the VA? And I want to hear from all of you, Doris, Patrick, Susan, everybody. Does each of you see the VA as a kind of clinical home for digital health innovators? I want to hear why and why not. And if you have an example of how that, that kind of power might be harnessed to address some of the most pressing challenges in cardiac care, I think that would really help to bring home that point. So Susan, since we ended with you, why don't you start?
Sure, happy to. I would say absolutely yes. We would see the VA as a very strong place for innovation. I think for many of the reasons that we heard from a number of the panelists, this is really about how do you democratize the way that we can start thinking about cardiac care and looking at the VA's mission. It seems very much aligned and thinking about this from an innovation purpose. I think when we do think about innovation, it also gives us an opportunity to speak about some of the financial alignment and things that come into play when we think about innovation versus sometimes the challenges that come from implementation and thinking about ROI, and having the opportunity to have a discussion with and a place with the VA to really say, how do we use tools and technology in a different way to truly advance health outcomes? And yes, we absolutely have to think about that from a financial and ROI perspective, but let's first start about thinking about what needs are, how do we address them, and then the rest will cascade.
Yeah, makes a lot of sense. Folks, you can just jump in here. I don't have to call, I can call on you, but I see Maulik's already chiming in, so take it away.
I was gonna say maybe I can go next. I mean, I think like some folks on the panel here, I have the fortune of actually being at the VA and Bedford VA. To the right. And if you think about just the fact that distance and travel time for some of these veterans, simple like
Maulik, I think your sound
for
is
patients
cutting out a little bit. It is, at least for me.
And that,
yeah, you're cutting out a little. Why don't
Got it. Let me move somewhere else. Somebody else can take the question.
Okay, cool. I'm gonna let Rob take it because I just noticed he unmuted. And
sure, Erin. Yeah, it's frustrating, I know, for Maulik. I'm anxious to hear what he has to say, so hopefully he'll find a good place for transmission. The VA should be, has always been the home for innovation in healthcare in what I would call the old-fashioned aspects of holistic care of the patient. And if we go back to the quality approaches that the VA brought in and the view of the unified electronic health record for the entire population, those are critical issues. And I don't see the VA as a place where the totally outrageous new thing would be first tried out, but I see it as a place, because of the patient-centeredness and the holistic approach, as a place where you can really work out the value and the implementation. So, an example that, I've recently learned about since Fitbit has joined the Alphabet family is there's a study that involved 50,000 veterans, with a very inexpensive technology that they were using for consumer reasons that yielded some very interesting looks at cardiovascular health and what could be done. Now that's a start, but the scalability is there. Now, would also like to just put in a quick plug. I think one of the greatest areas where we need innovation is the integration of community health and digital health. So I don't think you're going to solve the problem of digital literacy by sending people better tutorials on the internet. I think we're going to have people that visit others in their homes or when they come into a clinic and help them through it. And I see that as a great source of employment, but we got to figure out how to do it well. And I think the VA would be a great place to work these things out.
Yeah, that's really interesting, especially given YouTube's role. It is kind of seen as a place where people just go for information, but you're saying essentially that there's more than just that's necessary. Really good point. All right, who wants to take it away next?
I can go next, Erin. So, I obviously, to answer that question, I definitely think the VA absolutely should be and can be a home for digital health innovators. I think the question for us is in what capacity, right? So there is 3 elements we have to think about, or rather we think about as the patients, the clinicians, and the health systems. And I think there was a comment made before is how do you offer an enterprise platform that allows a practice to remotely track their patients, and in this case, hearts, using these different types of data devices and connected services. So in our case, this technology is being integrated into EMR systems, for example. So Cedars-Sinai Medical Center has integrated our enterprise system into their Epic EMR. So now what are clinicians looking for in this case? So I'm assuming they want deep validated data from all kinds of sensor devices. They want to have real time and, through trend analysis so that they can focus on the real treatment plans. But the patient is kind of satisfied on an everyday basis. And I do think from a patient point of view, I think they don't want to leave their homes. And that is one of the issues that we are seeing with, regular checkups where patients are not going as often to the hospital. So then how, as a system, can we collectively make services available where patients can offer or obtain deeper insights into their heart health? And that's these are all the parameters that we're trying to work around and work with, and really excited about partnering with the VA.
Thanks. Doris, I think you might be muted, but I see you.
If I may, I agree with what she's saying because I had although my home domicile is in Atlanta, Georgia, I have to travel to Nashville, Tennessee for my annuals and my every 6 months.
That is quite a distance.
Yes. So I was going very rarely. I mean, I was going when I first had it, every 3 weeks. I would travel back and forth. And it kind of got draining, Now it's every 6 months. But if we had some type of digital help, that would help the patient so much in having to go through all these testings and possible, EKGs or whatever it is. So I think it is, really I have to establish what the patient's needs really are. Because I might not need everyone is different, so they might go through a different process. And with something with digital health, that will keep everyone in the loop as far as the technology and the information that's being shared between both facilities and myself, so that is very helpful. Yes.
Got it. Amit, you led the Smart Heart program, right? It'd be great to get.
I think I was in their early stages. Yes. Yeah.
Awesome.
I think I might have been the fourth participant. Yeah.
And Dr. Shah, you were part of that as well. Could we get your perspective on just virtual cardiac rehab in general?
Absolutely. I think it's a tremendous opportunity here as we think about digital health. And Ms. Roundtree, thank you so much for participating. And absolutely, you were one of our first patients in the study, and it's definitely progressed since then quite a bit. But I think that this is something where, what we need to do is transmit tremendous amounts of information. We're really concerned and thoughtful about safety as well. We're asking people to exercise. And so there's the need for a lot of information that we would otherwise need to discuss over the phone, and we can do it much more efficiently with technology. Passive monitoring is a great opportunity for us to think about safety as well. And then as we think about having more time with the veteran and the time in between when they are exercising, that generic opportunity is there very strongly with home-based cardiac rehabilitation. And so being able to do this with veterans while they're at their homes, I think has really afforded us to get a lot more people served than would otherwise. For example, truck drivers who are on the road all the time.
Makes a lot of sense. Patrick.
I would only add that I agree. I mean, I think that the things like cardiac rehab and stroke rehab, for example, offer tremendous opportunity to improve people's health and to educate folks. We also really like the idea that Dr. Califf raised about engaging people to serve others, to be visitors, and there's an extraordinary opportunity to improve health that way and see what's happening directly, not just through digital means. The other components of this are around essentially behavioral and mental health as well. We've been thinking a lot about that at the American Heart Association, how to blend this heart and mind, and the state that many patients who don't want to be patients, by the way, feel that they're in, and depression and anxiety are a big part of what they're experiencing. And as well as Doris noted, you're sort of learning a new language. There's lots of pressures and things going on. The other opportunity that digital health affords us is to educate the families, the loved ones around the patient who have many of the, perhaps will have many of the same issues you're getting out in front of some of these things, in addition to just helping the patient or the loved one. So I think there's some ancillary benefits of these technologies that we probably haven't done enough to understand. I'll just say that fundamentally we're increasingly taking a whole health approach, whether we're working way upstream and hopefully more and more on the prevention side, but very much so on the, if you will, the downstream side, post-acute and chronic care and aging. This focus on resiliency and health and lifestyle is really just very important to us.
Yeah, I'm glad to hear the discussion of, not just patients, but creating more of a wraparound system that addresses, families, support systems, all these other things, and in order to pull them in and help supplement and support a patient in their care. I feel like as a reporter, one of the trends that I'm seeing is a more sort of holistic view where, in addition to, just treating a patient in the traditional sense, you're also pulling in social services, you're pulling in, a focus on things like housing, all different kinds of support systems rather than, you mentioned behavioral health, for example. Is that something that other folks are seeing too? And do you think that'll be a really important theme going forward in terms of bringing technology home to cardiac care?
Well, Erin, I think it's an important theme. The curmudgeon in me wants to just point out that our rhetoric and our action are not too tightly correlated right now in the U.S. In fact, there's a great editorial by Marshall Chen in the New England Journal of Medicine this week, in which he points out that there was an old quote, "You are what your record shows you are." And so while we're talking about holistic health, we're seeing this increasing disparity of health status and life expectancy that's very measurable and headed the wrong direction and affecting rural people and minorities specifically. And so there's also increasing evidence that digital health, at least as it's currently being rolled out, is having a much more positive impact on the well-to-do, highly educated, already activated people than it is on the rest of the community. So I like the rhetoric that you described. I think it's the right rhetoric. It's what we should aspire to, but we need hardcore measurement and alignment of payment with activity that actually deals with these issues directly.
Yeah, I'm seeing some nodding heads from panelists. So I think, Rob, you definitely hit a nerve there. Does anyone want to chime in with their thoughts on that point? All right, well, Maulik, I promised that I'd call on you when you hopped back in. So you're in the hot seat. Take it away.
Sure. Can you hear me okay? Apologies for that, by the way. No, I think the point Rob makes is a very valid one, right? Which is that if you just look at a different statistic, the amount of investment that's gone to digital health over the last 3 years is astronomical compared to the historic last 20 years even. But if you look at the results, to Rob's point, at least for the kind of patients that we see in clinics with comorbidities and complex social situations and complex medical situations, there hasn't been a tremendous benefit to that population. And the question really is, why is that? Is that because the barrier to entry is so low on the consumer, worried well, or healthy and the wealthy side of things, that companies have just gone there because of ease? Whereas what we really want to do is take the the challenging road of actually trying to implement some of these technologies, but you need the ecosystem to play well together. You need the policies. I used to always say, at least at our innovation lab at MGH, the 5 Ps, right? You need people, product, programs, price, and priorities. You need all these things to come together to actually make an implementation project be successful and scale. So I think in the next part of the conversation, maybe we can focus on that part of how do we get the right individuals and other parts of the ecosystem to come together to have this. But I think there definitely is a gap currently.
Yeah, I think that's an excellent jumping off point for our next question. Who wants to jump in with an answer? By the way, I just wanted to reiterate the 5 Ps you mentioned. I just wrote them down. People, product, programs, price, and priorities. I think that's really interesting. So yeah, let's move away. We're talking a lot about innovation. Let's talk about implementation. Let's talk about reducing inequity. I'd like to hear from all of you, what do you see as the primary means? Like what are some of the steps we can take to start to get there now?
I think one way to really think about it is if you really completely have a member-centric approach, not just on a piece of paper, but truly say, and when I say member, I think another thing is member and caregiver kind of go hand in hand, because for many of our patients' members, however, the terminology is used is the caregiver is hand by hand, right, is often involved in that. So thinking about that, and what you will often find is as you're truly doing that, there is a need to change operations, right? I think that's what Maulik is really, when we start to do those, the needs that a member and their caregiver will start to express suddenly dictate how the operational flow, how the technology needs to come, how we align our people resources in terms of our staff, what needs to be actually delivered, what our partnerships look like, all of those pieces. And they are not easy, and they're not easy conversations. But if that's really where that feels like a very good starting point to truly understand the needs deeply for members and caregivers and have that dictate how things are then actually executed.
Yeah, I would like to jump in, Susan. So I completely agree with your point. I think we have made significant progress, by the way, in the last 2 to 3 years, like just watching what has happened with telehealth to be, for example, right? But I think we have a long way to go towards truly integrating what we call digital health into, especially in the field of cardiology, right? So I think 2 steps, and I think, Susan and Maulik both kind of touched on this, is I think the healthcare sector really needs to continue investing in new digital solutions that patients want to use. So a lot of companies like ourselves, we've kind of bypassed the system and directly went to the consumer, and now we're going back into the system. But I think what the healthcare system needs, the systems need to do is recognize the technologies that patients like to use. And they are the ones then driving it back to the doctor saying, hey, I took my ECG using this device. What do you think about it? So that's how we're getting the pull. But this means that we need to focus on ease of use, intuitive design, of course, cost and reimbursement. And that onus of reimbursement comes back to companies like us, where we need to figure out how we fit in the reimbursement workflow so that the patients don't have to pay for these devices on their own, right? I think the second thing is the healthcare systems really need to invest in integrating these solutions. So one is to first recognize that they exist and customers are now using them and they want the empowerment, but it's a whole different allocation of resources when you start integrating them into your workflows, so that we can all collectively deliver these to the patients, in a cost-effective manner. And going back to the point of access, which is really truly what we all need to aim for, is affordability and access to anybody who needs any of these technologies wherever they are. So I think there's a lot to be done, but it's definitely a great start.
So
Yeah.
I'm sorry. So yes, I think the collective technologies would have helped me and my family tremendously. It was extremely hard for us to kind of wrap your head around what was going on. So if we've had something, not just on paper, but have something that was more, like I said, user friendly, something that, because while I'm in surgery, they could be, using the technology for their personal use of the knowledge that they would need and in my care, right? In my continuous care, what is next? What do I do? There's a lot of information that my family didn't understand, but didn't know how to ask. You know what I mean?
Yeah.
Maybe with the technology, that information would have been there for them while I was in recovery. What to expect during my recovery periods. You know what I mean? And all that technology could be right there for them during this whole process, and it would have helped them to understand me. Like as far as the medication, say, example, the prednisone. Everybody knows about prednisone and how it affects people. Maybe had they known about prednisone, they would have understood, and it would have kept us, not at each other's throat. You know what I mean? So yeah, the technologies would really help us tremendously.
Yes. I'm nodding vigorously, and I'm seeing other people nod vigorously, probably have had personal experiences either with their family or individually with prednisone. And I'm so glad we're talking about that. I mean, I've heard behavioral health mentioned a couple of times, and that's such a good point. I mean, we're often not told about these things. And the idea that you'd have a tool that while you're in surgery, your family is using already to prep for what's next, that's really smart and a great point. So thank you for that. Patrick, I know you were about to say something, so I'll let you.
No, Doris's voice is more important, but I'm glad she touched on those elements because I couldn't agree more. And one of the things we've been trying to work on at the American Heart Association is thinking about exactly those kinds of points and how patients and their families can understand the questions they should be asking, digital tools that allow them to capture information at the point of care and be able to route back into the clinical system in a smarter way, and just to understand what's happening amongst themselves and for the reasons that Doris described. The other thing to consider is how technologies can be used in rural and community health settings beyond direct care. We look at leveraging telehealth, for example, to provide expert cardiovascular consults to community health centers, right? And so there are ways to leverage technology beyond this kind of only the wealthy patients access technology in a clinical setting or on their own because they can afford them. And I think there's a tremendous opportunity to invest in community health programs and with entrepreneurs directly, and to leverage things like telehealth to make care more affordable and more practical for various parts of the country. So many good things that can be done with this technology for sure.
Erin, I'd just like to say, I think the VA is in a phenomenal position to be a driver here because of the comprehensiveness of the system and the vastness of it in the fact that it's dealing with a population that's aging with a lot of chronic disease and a lot of rurality, which is, a huge issue right now. And just to point out a couple of elephants in the room, I think we would probably all agree that despite the fact that many of us are focused on one thing or another, what we don't need is 500-point solutions. People are speaking pretty clearly now who are in positions to run health systems that they just can't have a point solution for everything. It drives the patients and the clinicians completely nutty. So the VA is in a position to create platforms, but it's also in a position to have good competition of the startups and the new things in a way that can be managed. So it's done in a measurable way, and not in a way that is just unleashed on people to try to figure out what to do with it. I'd also say the VA is in a great position to have people compete for the hard to conquer problems that we've all alluded to: rural, multiple comorbidities. Because I think Maulik said it really well. Right now, if you're just developing a digital solution, you can make money going to the wealthy, highly educated who are going to buy it outside of healthcare systems. And that's, nothing wrong with that, but it's not what we need here. And then I'd be remiss if I didn't mention, we all know there's another elephant in the room with the VA, and the issues that have arisen with privacy and extreme concerns about that and congressional oversight do make it a little tougher. And so I think the VA, has a job to do sort of politically to work out an environment where more things can be tried under careful supervision and not impeded for months to years because of these concerns. That's not an easy one, but we should acknowledge that that's an issue that needs to be considered.
So we're going to be moving into audience Q&A in 3 minutes. Before that, I want to ask one final question of all of you. But don't worry, you're not off the hook yet, because you're going to have to answer the audience's questions, which will probably be smarter than mine in a minute here. But since we are talking about implementation and moving away from just focusing on innovation, you all have to be thinking about technical criteria that are required to ensure that we're not just deploying these, as you said, Rob, 500-point solutions, but we're also integrating them and making sure that they can scale, particularly to the folks who need them most. So what kinds of criteria are you all talking about with regard to making sure that happens, to say, well, if there is 1-point solution, it can at least communicate with this other point solution, or to say, let's just all have kind of an open source environment where these kinds of tools and things can interact, data can be shared. Obviously, that is a tall order, but I'd love to hear a little bit from you. So who wants to take that one away? I will call on you. Susan.
So what we've been moving towards is really the idea of the functionality. So interoperability means many different things to many people, as we are finding. So we are very much focused on, here's the functionality that's actually required based on what we are hearing from our members' needs and the caregivers' needs, right? Putting that first. And then really being able to then work with our partners or our inherent tools within our system to say, can it actually meet these functions? And if not, why? And then what needs to be adjusted? It's a heavy lift. I won't say that it's not, but it feels like if we're focusing more on that, then ultimately those are the kind of ways that you get to the health outcomes that you need.
And maybe I'll add on to Susan's comments. I think, Erin, to your question, the way I think about this is at least there's 2 major dimensions when you think about having a single platform approach, which is the coverage of clinical conditions and coverage of patient acuity levels. To me, if I look at digital health fragmentation today, that's where it's like cardiology and national is using something different than pulmonology, neurology, orthopedics, like everybody's using their own thing. Right. And then if you look at even within that chronic disease framework, well, if you get to acute care, all of a sudden, none of the systems work. They're all outpatient based, right? So if you look at acuity of illness, acute, post-acute, chronic care, that's the complex matrix. Now, Biofourmis is trying to do that, but I think the critical challenge, though, is in order to do that, it will take a long time to have a single platform that'll have that kind of capabilities across all the clinical conditions and all the acuity levels. So what happens then is you have to find, to your point, a way to integrate in the short term all these solutions. Well, that traditionally the challenge for startups and companies is that requires investment on the system side, right? You could have 50 solutions in a marketplace, but it requires the IT system in the health system or payer or VA to then say, we will enable this thing, because in order to deploy it, we have to invest time and resources. So the question to me becomes, you need both parties to come to the table to say, we won't have that single solution. It's just not going to happen for at least like 5-10 years from now. You know, even electronic medical records took a long time, right? So how do we bridge that gap between now and then? And how do we come up with these standards or IT systems that can enable to do that? I think to me, that's the critical question.
Yes.
Yeah, just one comment on it, Erin. I think we see this in all industries, right? There's integration of technologies into few platforms, and then there's disintegration when innovation needs to happen. And then we go through this again. It's like, we've seen this in semiconductors, we've seen this in technology, consumer electronics. So I feel like it's going to happen in healthcare as well, of course. But I do think that going back to the previous point, I think health practices and systems need to invest in integrating the solutions that are customer friendly, and that, you know, and then on top of that, add more advanced, personalized, holistic features, as we are all talking about coaching cardiologists, medication reminders, data sharing, secure data sharing. All of that needs to happen. So I think I feel so happy to share that we are finally at a point as a startup, and we've been in business for 10 years, that the North Florida, South Georgia Veterans Health System in Gainesville is in process of implementing our CardiaMobile 6-lead device and our cardiac solution into the processing of all the incoming patients. And I don't think there are many startups, by the way, that can go through that lifetime to come to that point. So obviously we need to be much more alert about what is useful for the consumer. I don't think it is the customer's burden. It is the system's burden, which is all of us collectively. We need to solve this workflow issue versus having the consumer trying to figure this out on their own.
That's a great point. I do want to jump into our audience Q&A just because I'm already seeing the questions and they're really good. So let's see. I'm seeing some questions in the chat and some in the Q&A. Oh, here's a good question that ties in kind of everything that we were talking about. And I think all of you will have some sharp insights here. How important is EHR or EMR, electronic medical record integration, with technology for, you know, example, remote patient monitoring? How important is that integration across the ecosystem?
It's essential. The question is how, you know, when and how, and then at what level the integration occurs. And I also feel like the current version of EHRs, you know, this is a transient thing, transient in terms of years, not months, but we all know that ease of use of EHR is just nowhere near where it's going to end up being when we get this worked out. So we need some aggregator. You got your EHR information, you got your PROs, you got your digital health, and you got other kinds of information. It all needs to be brought together somewhere. Of course, the cloud was made to do this kind of integration, but exactly how is really going to be complicated. But without integration, we just have a bunch of disparate stuff. And I want to put in a word for the well-being of the clinician. Right now, the clinician is completely overwhelmed, and as great as the inbox is, allowing people to send emails to clinicians, there was a recent statistic that the average doctor is spending 2 hours after hours just answering emails. Well, you know, that's not sustainable. And so we're going to have to integrate if we're going to succeed.
If I could just add to Rob's comments, what I would say is, yes, agree 100% is essential, right? What I think you could do, though, is in the new world, be creative about what that actually means. So for example, used to be the remote patient monitoring data was just sent to the hospital, the clinician or the EMR, and somebody had to figure out what to do with it. So right, it was all about data, nothing about insights or actions. In today's world, you have virtual care teams. So if you think about the concept of task shifting or different role groups who can handle the action and the intervention on these data, you can imagine not burdening the primary physician of record with everything, right? They have to take care of patients in the clinic and after hours remote patient monitoring and all the prescription stuff and lab ordering. That's overwhelming and it's probably not sustainable. If we start thinking about teams and teams of individuals working, and then I think that's interesting to think about how do you actually, again, get effective deployment of these solutions and be a little more of a broader view of what that means, like instead of a single physician.
Okay, I see that we have a panelist who would like to ask a question live, which is awesome. So I'd like to hand over the stage to Englam.
Sure, thank you. I apologize that my last name came first on my video here, but
Christian.
Yeah, no problem.
Sorry to introduce you that way.
Sure. I'm a downstream marketer within Medtronic Care Management Services, and we're thinking a lot about this as we assist the VA in really delivering these next sort of generation or iterations of digital health. And Dr. Califf had sort of dove into this in one of the questions, but my inquiry is around if any of the panelists have insight as to how better provide or educate, empower, engage with a lot of the high-risk rural populations where maybe broadband doesn't quite have that type of access. And I think, there's some of that language barrier on how to do it if they're not quite as digitally literate as some more urban populations where it's more pronounced to help in their care, but really take that to the next level so that vendors like us are not consistently iterating on something that we just assume is widely accepted when, the most high risk of these populations are still, sort of falling by the wayside. But that was my question, asking for some insight on that.
Thank you.
I mean, I always have something to say, but so I'm happy to yield to other participants. But I'll just try to quickly say I meant what I said before. Well, first of all, let me just say one thing we can do is hope that Congress comes to its senses and passes legislation that will fund broadband access. I was amazed to learn in the early part of the pandemic, there are even huge areas of New York City that don't have broadband access. We got, this is a fixable problem and it's not that expensive and it would help a lot. But even with all that, I really think this is a human interaction issue. And, the economics of rural America right now, you don't need so many people to run a farm. And so employment is a huge issue. And I could see really nice jobs for people helping others benefit from the digital environment by just helping them learn how to use the technology and get the right stuff in the home.
Yeah, and I think there certainly are players springing up like Starlink and others trying to focus on the rural coverage issue. Again, these can be costly services as well, but they're trying to address. And again, as you think about what telehealth can do, there's tremendous opportunity to reach people directly. And as Dr. Califf said, there's a much better way to reach people on a personal level that it doesn't always have to be technology. I think these things can work together. And I have a friend personally, and I have someone maybe who's watching to a certain extent from a technology point of view or devices and systems that are working for me to watch me in a positive way, not in a negative way.
I think this is also an opportunity to really understand what a community needs and how they often come together to really think about communication and resourcing when you do have challenges. So while we are waiting on some solutions, like thinking about broadband accessibility and having that happen, thinking about, how can you really leverage and understand how a community actually helps each other and intersect with those points to be able to share this? Because I would agree with all the panelists here, this is The tools are only as good as the sort of human connections that we can make with them. So part of it is still going to be boots on the ground, understanding what does a community need and how can we really utilize the resources that they've already created to make connections when you are in a remote or rural, kind of environment.
Got it. I just want to chime in with a quick time check. We do need to wrap up in the next minute or so. So if anyone has any last thoughts they'd like to share, I'd welcome them now. Anyone want to chime in? Okay, great. Well, on that note, I'd like to thank all of you so much for participating today. This has been great. I really enjoyed it. I hope you all did too. Thank you. Huge thank you to our panelists and to our audience for asking such smart questions and keeping the chat alive. Special thank you to Doris for being a patient, going through this process, and being willing to share parts of that experience with us. Really appreciate it. Thank you again, everyone, and I'll let you hop on to the next session.
Fantastic, Erin, what a tremendous session. Thank you to you, Doris, Rob, Susan, Patrick, Maulik, Priya, and Amit. I think that this was, absolutely sort of struck at the heart of why partnership between VA and industry is so important. How do we avoid those 500 point of care solutions? How do we sort of, create a system that can accommodate and integrate and demonstrate global best practice here? You teased that out for us beautifully. And Doris, you reminded us that we need to keep the veteran and the patient at the center of all of this alongside our clinician colleagues. Absolutely tremendous discussion, everyone. Thank you.